So in this video, we're going to examine some of the treatment options that exist for back pain. This is a nice kind of overview of some of the various treatment approaches that exist for back pain. Notice the first line therapy are your NSAIDs and pain relievers. Notice acetaminophen is not an NSAID. Kind of your second line therapy is this kind of gray zone here between these muscle relaxants, also known as spasmolytics, and steroids. Steroids used to be kind of the second add-on therapy for NSAIDs, but they haven't really been shown to be as effective as previously thought. And a lot of physicians are just kind of going to these this class of drugs called muscle relaxants or spasmolytics as kind of the appropriate add-on therapy. So they're both kind of first-line therapy as of 2018, 2019. There are some second-line therapies, the addition of a SSRI, specifically duloxetine, or the addition of a central analgesic such as tramadol. And of course, the kind of the third-line therapies are the opioids. And not because they don't work, they work extremely well, but you probably have heard something about the opioid epidemic that's plaguing our nation, as well as some of the other Western countries. The use of opioids has skyrocketed for pain management, and we have other discussions about that in particular outside of this video. So in terms of treating back pain, we're really kind of focusing on the management of pain. And so to produce analgesia, we're going to utilize various drugs, many of which listed here, to kind of lose the ability to feel pain while being conscious, of course. And so this is kind of a nice little summary diagram kind of showing where some of these drug targets have their main mechanism of action or their main clinical effect. And of course, these are not in any particular order. But, outside of drug therapy, exercise, physical fitness has been shown to be very powerful, assuming the patient is mobile, at treating, alleviating, and managing back pain. So here you see a couple doing core exercises. Core strengthening is really important for controlling back pain, as well as certain cardiovascular type of diseases that utilize a lot of leg muscles and also core muscles too. And so, the elliptical is another great kind of tool for treating back pain. And part of the kind of clinical approach outside of the pharmacology, of course, is to utilize some of these physical therapy type of practices to kind of get the patient more mobile and really, off the meds, and we really don't want them to go into the persistent opioid use. So the first line therapy, as we said before, is NSAIDs, and this is in another lecture series, and so I don't need to go into great detail about NSAIDs. You can click on that link and it'll take you there. NSAIDs, two in particular, have been shown to be very effective in terms of controlling back pain, specifically ibuprofen and naproxen. And of course, the non-NSAID, acetaminophen, works very well. Kind of along those same lines, the steroid lecture is elsewhere. The steroids that have been shown to be somewhat effective include methylprednisone, and the clinical data has come out relatively recently, in the last maybe 3 or 4 years, stating that even these short courses of steroids are not as robust as previously thought. And so I left it in here because you can still see it on certain treatment paradigms. And it's, there are side effects to steroids, but, all in all, they're relatively benign, especially for short courses. And so, but the focus of this lecture was really to kind of talk about this next group of drugs called the muscle relaxants, or also known as the spasmolytics. And the prototype here is cyclobenzaprine under the brand name Flexerol. From a mechanistic standpoint, this drug increases norepinephrine release in a specific brain region called the locus coeruleus. and that also will inhibit alpha motor neuron activity in the ventral horn of the spinal cord. This drug also has some antimuscarinic effects, and so some of these patients complain of sedation, confusion, dizziness, and there are some GI disturbances. Many patients complain of abnormal dreams, and some can see an exacerbation of vertigo. Another muscle relaxant is baclofen. The mechanism here is not entirely completely understood. We do know that it's a GABA agonist, particularly a GABA subtype B agonist, and from that standpoint, we know that it works presynaptically to essentially reduce the release of excitatory neurotransmitters. So remember, GABA is basically your prototype inhibitory neurotransmitter, and so it's going to dampen or kind of reduce the excitation components of its neighboring neurotransmitters. Postsynaptically, it'll enhance the inhibitory transmission as well. Side effects to baclofen include sedation and confusion, much like the other muscle relaxants, muscle weakness, vertigo, and nausea, all of which are quite common. Baclofen can be administered several ways, orally, transdermally, intrathecally. There's pump infusions as well, but it does contain a black box warning telling patients not to abruptly withdraw, particularly the intrathecal administration of baclofen, specifically in patients who have been using it for over 12 months, because you can see a hypermetabolic state. And so that state will look like impaired mental status, muscle rigidity, and there'll be severe rebound spasticity. The pathophysiology of which we're not really going to get into in this block at all. You will understand that more once we complete the next upcoming block, which is going to be brain behavior and cognition. So there can be multiple organ failure with abrupt administration of baclofen, which is why you don't really see this drug being used as often as it once was. Benzodiazepines can also kind of fall into the muscle relaxant slash spasmolytic category because they are GABA agonists as well, but these are GABA type A agonists, and they profoundly enhance the inhibitory neurotransmission. Ironically, these drugs can be used, but they are not approved by the FDA for the treatment of back pain. There's another drug called carisoprodol, the full mechanism of which is unclear, but it's in this kind of same category of being a GABA agonist. And so it works pretty similarly to the benzodiazepines in the previous slide. We're going to see an enhanced inhibitory neurotransmission. Sometimes you can see this drug formulated with acetaminophen under the brand name Soma. And of course, the side effects include serotonin syndrome, sedation, and some dependence liability. So there is a little bit of abuse potential with this drug in particular. So this is basically the bulk of the muscle relaxants. The next drug kind of leads us into the second tier of muscle relaxants, which kind of have a different mechanism of action. But understand that when we talk about GABA and its ability to be an inhibitory neurotransmitter, it's in relation to some of the neighboring neurons that it's associated with. And so you can see some of these kind of depictions over here where GABA release by one neuron is affecting a neighboring neuron's neurological activity. So a lot of this stuff will be kind of further delineated in the next course, and so this is also kind of an introduction to those mechanisms.